Hello and welcome to Lecture 9 in Principles of Exercise Therapy. This week we're covering range of movement. So a little bit back to our centering slide. What's physiotherapy about? It's about human anatomy and physiology, human movement and function, maximizing wellness potential, minimizing disease and injury, and solving real-world problems. That mission statement is important, commit it to heart, because that's really the why behind what we do. So, range of movement. What have you got to learn today? I want you to be able to describe range of movement. I want you to describe the principles applied to stretching. I want you to explain why soft tissue might get tight, describe the stretch reflex, and also to describe plyometrics. Okay, the stretch shortening cycle, effectively jumping for the lower limb. So the principles of exercise therapy, we've got adaptation, specificity, progression, regression, overload, reversibility, time out, behavioral change, individuality, lifestyle integration, law of diminishing returns, and your responsibility. So range of movement is the measure of movement around a specific joint or body part. The distance could be linear or angular in a movable object that may normally travel while properly attached to another. So the distance and direction a joint can move between the flex position and the extended position. Take, for example, the knee joint. Fully flexed when the knee is bent, fully extended when the knee is straight. So the act of attempting to increase this distance through therapeutic exercise can be called stretching or range of motion therapy, which is stretching from flexion to extension for physiological gain. So the way that we measure range of movement is we can use the Mark 1 eyeball, where you can guesstimate it. The more experienced a clinician you are, the more accurate you are. As a student, we'd like you to use a goniometer, because that way you can be accurate, that way you can be valid and repeatable. The other thing is you can also use a tape measure when you're using sort of knee to wall as well. So what happens when we stretch? So the muscle fibre is going to lengthen. We've got sarcomere elongation. The area of overlap between proteins decreases progressively within each sarcomere. Muscle fibres reach maximum length. Force is applied to the surrounding connective tissue. Collagen fibres within the connective tissue align along the direction of the force that is applied. So this is important that we get the direction of stretch correct. So here we can see a muscle that's being contracted and a muscle that's being stretched, and in the middle it's relaxed. Tissue types. Different tissues respond to immobilization and stretching in different ways. So we've got plastic and we've got elastic structures. So connective tissue, collagen fibers. So collagen fibers resist tensile deformation, they give strength and stiffness, and they have a maximum elongation of about 10%. Elastic fibers give extensibility, elongate easily at low load, and they have a max elongation of 150%. So the behavior depends on the proportion and the orientation of the fibers. Why do we stretch? As physios, we regularly encounter patients with well-established limitations of joint movement. So we need to identify the soft tissues that are prone to shorten and lose their extensibility. So common causes might be contractures of the joint capsule, adhesions within soft tissue, muscle spasm and tightness, neural sensitivity, and pain inhibition. Proprioception. Feedback mechanisms which provide information on the body assist in movement. They detect, control, and respond to changes in physical displacement, tension, force, and pressure. So there's an example. Okay, step 1, we've got stretching. Stretching of muscles stimulates muscle spindles. Okay, step 2, we've got activation of sensory neurons. Step 3, the information is processed at the motor neuron. Step 4, we've got activation of the motor neuron. And step 5, we've got contraction of the muscle. Proprioception. So proprioceptors and mechanoreceptors relating to flexibility are the muscle spindle, which is in the muscle fibre, the Golgi tendon organ within the tendon, and Pacinian corpuscles also within the tendon. So here we got the tendon, okay, that then becomes the muscle. This is the Golgi tendon organ, the GTO, okay, which is located in here, okay, and then you've also got the muscle spindle here, which is located in the muscle. So this is the spinal cord reflex arc, okay. So here you can see, okay, feedback from the Golgi tendon organ going into the spinal cord, okay, coming out the relaxation response, okay, of the muscle. Pacinian corpuscles, the central nerve fiber extending through its core, okay, surrounding it the multiple concentric capsule layers. So compression anywhere on the outside of the corpuscle will elongate, indent or deform the central fiber. So the stretch reflex. So top left hand corner of the screen you can see someone doing an ankle jerk reflex with the reflex hammer. So the stretch reflex is called a myotatic reflex, and the muscle contracts in response to stretching within the muscle. Okay, it's a monosynaptic reflex which provides automatic regulation of skeletal muscle length. When a muscle lengthens, the muscle spindle is stretched and its nerve activity increases. The stretch reflex gives the muscle the unique ability to adjust to differences in load and length without having to engage the brain. So this is happening at spinal cord level. Okay, it doesn't need any higher function from the brain. So stretch reflexes. So on the left, okay, this is a muscle during stretch. Okay, on the right, this is a muscle during contraction. Okay, remember that the muscle is being stretched. The stretch is caused by contraction of its antagonist. So imagine the biceps, okay, on a bicep curl is the prime mover, the agonist, and the triceps is the antagonist. So as the bicep contracts, the tricep has to relax and lengthen. And this sensory information contributes to maintaining proper muscle tone. More pictures here. Sensory nerve. Okay, muscle spindle sensing the muscle is stretching. That sensory nerve is fed into the spinal cord. Okay, and the motor nerve responds. The muscle contracting in response to the stretch. The stress strain curve. This is important. Okay, so at the top here, on the y-axis, we've got stress. On the x-axis, we've got strain. So this is the toe region here, okay, and this is normal physiological range. Right at the top here, okay, you're going to get micro tearing and failure, okay, but if you take that well beyond there, you're going to get rupture of those structures, okay, so that's the stress strain curve of collagen. So types of stretching. We've got manual stretching, which is when the therapist does the work. Mechanical stretching, such as serial splinting or casting, like in talipes or club feet in babies. And then we've got self-stretching, using either body weight or accessories such as a towel or a belt. Okay, stretching should be felt in the belly of the muscle, so the center of the muscle. It should not be felt at the origin or the insertion. Okay, that's important to remember. So manual stretching. Okay, here you can see the therapist applying a force to the tissues of the posterior chain, mostly the hamstrings here, and you're going to hold that stretch anything between 30 to 60 seconds, and you might do that several times. Early stages, you want the therapist in control, and remember, this is not really an exercise, it's a passive movement, so the patient is allowing the therapist to stretch them. So we've got mechanical stretching. So here you can see in babies born with club feet, talipes as well, what happens is a series of splinting because the bones are malleable and you can change that club foot into a functional foot position. Here we've got splinting and casting, and these are all manual types of stretching. Self-stretching. So flexibility exercises or active stretching, the patient can do them independently. Here you can see somebody doing a hamstring and posterior thigh stretch, but the alignment is crucial, okay, and patients can also use their own body weight. So stretching exercises, two types of stretching exercises, static stretching and dynamic stretching. So dynamic is quite ballistic in its nature, so we have to be cautious. It's normally quite progressive and functional, and it requires a succession of active movements, and that's going to enhance neuromuscular control, so it's perfect for a warm-up. So we always do dynamic stretching in a warm-up. We wouldn't do it at the beginning of a session anymore, because it's going to down-regulate our neuromuscular control. So static stretching is commonly applied, it's slow and controlled, it's for fine motor control and postural awareness, and we do this as part of the cool-down. And then we'll also talk about PNF, neuromuscular facilitation, proprioceptive neuromuscular facilitation, contract relax in this case. So dynamic stretching, this is rapid, forceful, high speed and high intensity. It's recommended really for active populations. We've got to be careful because it's difficult to control. Weak muscle tissue could injure, and dense connective tissue becomes brittle with rapid stretching. So it's contraindicated for the elderly, for the sedentary, or those with pathology. Static stretching is where the tissues are lengthened past the point of resistance, then held in a lengthened position for a minimum of 30 seconds up to a minute, and it can be combined with mechanical stretching such as casting, and it can also be progressive or cyclical. So the principles of static stretching: minimum 30 seconds. We're going to give the patient some feedback and some correction. Okay, normally you're stretching over two joints, so the muscles originating from the axial skeleton. Okay, we've got to be careful about the order effect. We've got to educate the patient on how they should feel, because the muscle stretch needs to be felt in the belly of the muscle, not at the origin or the insertion. It's a slow, sustained stretch, and we don't want any bouncing because we're not doing ballistic stretching. So end of range. There is an end feel to end of range, and it's important as a physio that you get used to having this end range feeling. Okay, that's where basically the joint has run out of places to go. So if you just straighten your elbow extension, that's a bony end feel because the bone is blocking any further movement. Okay, if you bring your fist up towards your shoulder, that's a soft end feel because that's soft tissue accumulation there, and you can feel the difference between the two. So stretching exercise. So we've got to make sure that we concentrate, make sure we're centered, make sure we've got control, make sure we're not holding our breath, make sure we're precise, and make sure that the movement is flowing. Okay, and these are principles that we can use from Pilates. So we've got alignment and stabilization, the intensity, the speed, the duration, and the frequency. So stabilization. So one attachment of the muscle must be fixed, and that's normally the proximal, okay, towards the midline. Okay, and the stretch is felt over the joint that crosses the muscle. Alignment. Alignment of the body segments will influence the tension in the soft tissue. You must consider the attachments and all adjacent joint positions. So here we can see stretching of the pecs. Okay, here, okay, we're stretching the pecs more in the sternal fibers just because of the angle of the arms, and here more the clavicular fibers of the pectoralis. And all we've done is same exercise, same stretch, but different position. The intensity, so the force that is placed through the tissue. Generally, you want to use low load, so low intensity with high duration, to reduce that kind of muscle guarding effect. Effectively, the muscle just melts into the stretch, and the optimum effects will be to reduce the risk of that muscle guarding effect. So duration, the period of time that the force is applied to the tissues, and you're going to hold it in that lengthened position. Okay, again, 30 to 60 seconds is what you're after. Sometimes you're going to do longer, maybe up to 2 minutes. Depends on the individual's tolerance. Okay, and there's a lack of agreement about the optimum time of stretch. So summary of stretching. So we've got static and dynamic. Okay, so we've got the features of the technique. One is fast, one is slow. The duration, okay, one is progressive, the other is sustained. Okay, so the dynamic stuff is for end range rehabilitation, late stage rehabilitation, and static stretches for early, middle, and end stage. Okay, remember, dynamic is more for the sports and active people, but static stretching is for everyone. So neuromuscular inhibition. Okay, this could be referred to as proprioceptive neuromuscular facilitation, or PNF. Okay, we're not using true PNF here, we're just using contract relax, which you'll cover in the practical session. So the antagonist contracts, so that you contract the opposite muscle and you get reciprocal inhibition, which describes the process of the muscles on one side of a joint are relaxing to accommodate the contraction of the other side of that joint. And then you've got agonist contraction and then relaxation. So you contract the shortened muscle. After a maximal contraction, you get a maximal relaxation. And all this will become clear in the practical session. So contraindications to stretching. Like with all contraindications, okay, these are important that we screen for these. So if they are early in that soft tissue healing process, then some stretching is going to be contraindicated. Any recent fractures, infection, hematoma or surgery needs to be considered, and we don't want to go beyond a bony block or an empty end feel. And obviously non-compliance with therapy will come into it also. So the evidence behind stretching. So static stretching doesn't cause any long-lasting changes in soft tissue length. Okay, and it could be more to do with the stretch tolerance or to do with the fact that the muscle is weak and needs to be stronger. It doesn't reduce the incidence of injury. So stretching doesn't reduce the incidence of injury or delayed onset muscle soreness, DOMS. Heat and ice can improve effectiveness if applied during the stretch. So basically warm muscle is better at stretching, like in the hot yoga room, and all studies are generally done on healthy tissue, not injured tissue. So stretching and strengthening, according to Janda. So simply stretching muscles that are tight only address part of the problem and rarely get to the cause. So the weakness causes the tightness and the tightness causes the weakness. So you can't fix only one because they're mutually dysfunctional. Muscles prone to weakness usually function as stabilizers. Muscles prone to tightness usually function as mobilizers. So you've got to consider the underlying cause of muscle tightness to be a dysfunctional stabilizer that causes movers to shorten in an attempt to create support. Yeah, get your head around that. Okay, we're on the stretch shortening cycle now, or plyometrics. Okay, here we've got a rapid eccentric movement followed by a very short phase of amortization and then the concentric phase here. And this is basically a jump. So the stretch shortening cycle, here we've got someone skipping, is an active stretch eccentric contraction of a muscle followed by an immediate shortening concentric contraction of muscle at that same muscle group. Okay, to get that jumping rubber band effect. So attaining a pre-stretch of the muscle causes it to be lengthened eccentrically, so tension is developed in the muscle. This is how the body works, like a rubber band. Stretch shortening cycle continued. So the tension created in the muscle can be used to help increase the strength of the following concentric contraction. So you can jump higher. The concentric contraction must take place immediately after being stretched, or the tension created dissipates as heat. And this phase between the eccentric and the concentric is called amortization, and you want this as short as possible. So we've covered everything in this lecture. Hopefully you can now describe what range of movement is. You can describe the principles applied to stretching, to explain why some tissue might get tight, and be able to explain both the stretch reflex and what plyometrics are. Okay, and we've got some references should you need them. Thanks for listening, and we'll see you in the practical.